Hello everybody and welcome to our module on immune deficiency syndromes. In general, you can develop a deficiency of the immune system when you have dysfunction or loss of one of the important components. So for example, if you lose T cells or B cells or granulocytes or complement. In clinical practice, most of the immune deficiency you will see will be acquired. It's either from people with HIV or much more commonly it's from chemotherapy. Chemotherapy is administered to kill malignant cells, but as a side effect, it often also kills cells of the immune system. What we're going to talk about in this module, however, are rare causes of immune deficiency that are either genetic or congenital. These usually present in infancy with recurrent infections, and they happen because babies are born missing an important component of the immune system. The first immune deficiency syndrome we're going to discuss is called X-linked A-gamma-globulinemia. It's also called Bruton's A-gamma-globulinemia, named after a colonel in the military who was a physician who first described the disorder. It's an X-linked condition, as the name implies, and it occurs because B-cell precursors fail to mature into functioning B cells and plasma cells. Children born with this condition cannot make light chains, and the reason they can't make light chains is because they have a defect in the Bruton tyrosine kinase gene. So if you can't make light chains, you won't have receptors on your B cells and you won't be able to synthesize antibodies. The symptoms begin at about 6 months of age, and the reason they occur at this age is because this is when the maternal antibodies begin to fade away. Children with this condition present with recurrent respiratory bacterial infections. They have lost the opsonization effect of antibodies. H. flu and strep pneumo are common pathogens. They are encapsulated bacteria, and you really need antibodies to coat encapsulated bacteria and tag them for phagocytosis in order to clear these pathogens. A classic presentation of an undiagnosed child is recurrent otitis media, because otitis media is caused by these two pathogens. They may also have sinusitis or pneumonia. In addition to the respiratory bacterial infections, these children also get lots of GI pathogen infections, and that's because they've lost IgA to protect their mucosa. So they can get infections with enteroviruses like echovirus and poliovirus and Coxsackie virus. All of these viruses enter through the GI tract, and when you don't have IgA to block their entry, it's easier for them to cause infection. These children can also get severe infections with Giardia. Giardia is a GI parasite, and you can just remember that it ends in the letter A for IgA. You really need IgA in order to clear Giardia. And as you will see in a number of these disorders, when you're missing IgA, recurrent and severe giardiasis is a serious problem. Key findings in support of this diagnosis include an absence of mature B cells in the peripheral blood. Mature B cells have CD19 and CD20 on their surface. They also have the B cell receptor, and cells like this will be missing in the peripheral blood. There will be underdeveloped germinal centers in the lymph nodes. Recall that the germinal centers are where the B cells live, and these will be obviously underdeveloped in this condition. And then finally, there will be an absence of all classes of antibodies. And you can treat this condition by administering intravenous immunoglobulin, which is pooled immunoglobulin from humans that can replace the antibodies that are missing in children who have this condition. The next immune deficiency syndrome we're going to discuss is a selective IgA deficiency, and this is relatively common in the United States. It's estimated that about 1 in 600 people have this condition. People with selective IgA deficiency have defective IgA-producing B cells. The exact mechanism is not known, but the underlying problem is that they cannot produce IgA antibodies. Most patients with this condition are asymptomatic, and they aren't aware that they have the deficiency. When people are symptomatic, they develop recurrent sinus and pulmonary infections, and this is because you need IgA in the mucosa of the respiratory tract in order to defend against invasion by pathogens, especially bacteria. So these people can have recurrent otitis media and sinusitis and pneumonia. In addition, they can develop recurrent diarrheal illness from giardiasis. You really need IgA to coat Giardia in order to clear this infection from your GI tract, and people who are missing IgA for any reason will often have problems with Giardia infections. There is a risk of anaphylaxis when people with IgA deficiency receive blood transfusion. There may be IgA antibodies in the blood products that they receive, and they may have produced antibodies against IgA because they are IgA deficient, so they can tolerate antibodies in their plasma to IgA. And then finally, lupus and rheumatoid arthritis are very common in people with an IgA deficiency. About a quarter of patients will develop one of these conditions. The mechanism for this association is not known. You can make a diagnosis of IgA deficiency by finding a low serum IgA level. Less than 7 is the level that's often used as a cutoff. Importantly, the levels of IgG and IgM will be normal. As I said before, most patients with this condition are asymptomatic and require no treatment, but in some patients who have recurrent infection, prophylactic antibiotics are used. Also, in some cases, IVIG is administered, so this is an interesting therapy for IgA deficiency. IVIG contains little or no IgA. It contains mostly IgG and IgM, and the idea here is to administer lots of IgG and IgM to these patients so that those antibodies take care of any infections. And then finally, a special feature of this condition is that many women with IgA deficiency have a false positive beta-HCG pregnancy test. So why does this happen? It turns out that antibodies called heterophile antibodies are produced in some patients who are IgA deficient. And these antibodies lead to a false positive beta-HCG test, and in fact up to 30% of IgA deficient patients test positive for beta-HCG. And in the literature, you can unfortunately find case reports of women who had exploratory laparotomies looking for an ectopic pregnancy because of a positive pregnancy test when in fact they were IgA deficient. Our next immunodeficiency disorder is common variable immunodeficiency, or CVID. This is a strange name. It was named this in the 1970s by the World Health Organization. What they did was lump together a bunch of rarer disorders into one disorder. That's why it gets the name common. And then it's variable because there are variable degrees of immunodeficiency within the patients who have this condition. The cause of CVID is defective B-cell maturation, so there is a loss of plasma cells and antibodies. There are many underlying genetic causes, and most cases are due to an unknown cause. There are more than 10 gene mutations associated with CVID. They are very unlikely to ask you on step 1 which gene causes this condition. And an important thing is that it is often sporadic, so there is no family history. Patients with this condition have a normal B-cell count, but they are missing antibodies. Usually they're missing IgG, and sometimes they are also missing IgA or IgM. The reason it's called variable is because there are varying degrees of loss of antibodies. In many ways, common variable immunodeficiency is similar to X-linked A-gamma-globulinemia. These patients can have recurrent respiratory bacterial infections. They can also get GI infections like enteroviruses and giardiasis if they're missing IgA. A couple of key differences that will help you to identify this condition in a board question. First of all, it's not X-linked, so it's more likely to affect females. And then CVID is very unusual among the immunodeficiency disorders in that it has a later onset. Most people don't develop this until after puberty. The majority of cases occur between 20 and 45 years old. In addition to the immune dysfunction, these patients have an increased frequency of autoimmune diseases and malignancies. In particular, they often get rheumatoid arthritis and pernicious anemia and lymphomas. And we saw in selective IgA deficiency that those patients also were more likely to get autoimmune diseases like rheumatoid arthritis and lupus. And really the way to think of these conditions is not just as immune dysfunction, but as immune dysregulation. So they are more susceptible to bacterial infections, and they are also more likely to get autoimmune diseases and sometimes malignancies. So now we've talked about 3 different B-cell disorders, and I've summarized them on this table along with some of the features that can help you distinguish one from the other. So first of all, look at the B-cell count in the peripheral blood. Only in Bruton's will there be a low B-cell count. The antibody levels are low in all 3 disorders, although in IgA deficiency there is only a decreased number of IgA antibodies. In the other disorders there are decreased levels potentially of all classes of antibodies. The symptoms all involve the sinopulmonary tract and the GI tract. That's where the mucosal layers are, where antibodies, especially IgA, are very important. And then some special features that are unique to each disorder only in IgA deficiency is there the false positive beta-HCG testing. These patients also commonly have lupus and rheumatoid arthritis. Bruton's often occurs in infancy, and CVID often occurs later in life in the 20s to 40s, and patients with this condition also develop autoimmune disorders and lymphoma. Now we're going to move away from the B-cell disorders and talk about T-cell disorders, and the first one we'll discuss is called thymic aplasia or DeGeorge syndrome. In this condition, the thymus fails to form, and therefore you have a complete absence of mature and functional T-cells. This disorder occurs as a result of the failure of the 3rd and 4th pharyngeal pouches to form. So let's review what the pharyngeal pouches are. On the left side of the screen is a fetus at about 24 to 28 days old, and you probably recognize some of these structures. This is the formation of the head here, the eye is noted here, and there are these little bumps that begin to form right here, and those are called the pharyngeal arches. The little grooves between each bump are called pharyngeal grooves. If we were to dissect this fetus like this and turn it over and look down at it this way, we would see something like what's on the right side of the screen here. These are the pharyngeal grooves right here, these little spaces between each little bump, and each bump is a pharyngeal arch, so these are the pharyngeal arches right here. Inside there are these pouches formed. I'm marking them here with my white pen, And these pouches are called the pharyngeal pouches. They are between the pharyngeal arches inside the fetus. And those are what need to develop in order to form the thymus. And these two that I've marked down here at the bottom are the third and fourth pharyngeal pouches, and they are what's going to fail to develop in thymic aplasia. Of note here, these central structures are going to go on to develop the pharynx, and this can help orient you to the other abnormalities that are going to go hand in hand with thymic aplasia. As we'll see in a minute, it's not just the thymus that fails to form, but many other structures don't form as well. Most cases of thymic aplasia occur because of a chromosomal deletion on the 22nd chromosome at the Q11 position. And a key point here is that these are usually spontaneous deletions, and it's not a familial syndrome passed on from parent to child. There's a classic triad of symptoms that develop in children with thymic aplasia. The first set of symptoms come from loss of the thymus. This is where you lose T cells, and these children have recurrent infections. We'll talk more about that in a minute. The second problem these children have is loss of the parathyroid glands. The third and fourth pharyngeal pouches contribute to many structures in the neck in addition to the thymus, and one of those structures is the parathyroid glands. So with absent parathyroid glands, these children will have hypocalcemia and tetany. And then finally, children with thymic aplasia often have congenital heart defects, especially congenital heart defects at the top of the heart, which are called conotruncal defects. The pharyngeal pouches influence the development of the upper portion of the heart, and that's why these heart defects develop. So the heart defects that occur are an abnormal aortic arch, a truncus arteriosus, tetralogy of Fallot, and then finally you can see ASDs and VSDs. The immune symptoms that develop all have to do with recurrent infections. Not having mature T cells is like having end-stage HIV or AIDS, so these children get viral and fungal and protozoal infections. They also get intracellular bacterial infections. Interestingly, the immune symptoms sometimes improve a little bit with age. Recall that T cells are synthesized in the bone marrow, but then they mature in the thymus. When the thymus is missing, they sometimes mature in other locations in the body. And then finally, these children often have facial abnormalities like a cleft palate or a mandible problem, and this is all related to failure of the third and fourth pharyngeal pouches to develop normally. One of the most important clinical findings of thymic aplasia is absence of the thymus shadow on the chest X-ray. The thymus is relatively large in newborns and they have a small chest, so usually there is a large faint white shadow seen on chest X-ray. This will be absent in children who have thymic aplasia. Now importantly, the thymus gland is also absent on chest X-ray in another immune deficiency syndrome called severe combined immunodeficiency. But SCID is purely an immune cell problem. It does not have all the associated abnormalities that thymic aplasia has, like low calcium and facial and heart abnormalities. If you see these things, then they are talking about thymic aplasia. If you see a normal child with no calcium problems, then they are probably talking about SCID. In thymic aplasia, there is a low T cell count, obviously, and there will be underdeveloped T cell structures. The boards like to see if you know where the T cells live by asking you which structures will be underdeveloped in thymic aplasia. So the paracortex of the lymph nodes will be underdeveloped, and the periarteriolar sheaths in the spleen will be underdeveloped. There are two treatments that have been used for this condition. Thymus glands have been transplanted in a small number of cases, and then sometimes hematopoietic stem cell transplantation has been done. The next immune dysfunction syndrome is the hyper-IgE syndrome. It's also called Job syndrome, named after the character in the book of Job in the Bible. You may know that Job was cursed by Satan and had many plagues cast upon him, and one of them was a rash all over his body, and this syndrome involves a rash, and that's why it's called Job syndrome. This is a rare, poorly understood syndrome. It involves immune dysfunction along with skin and bone findings. The two key cellular abnormalities that you need to know about for hyper-IgE syndrome are defective CD4 positive Th17 cells. Th17 cells are T cells that produce IL-17, and they are abnormal in this condition. The second problem in this condition is the loss of attraction of neutrophils. Neutrophils are normal, but they fail to be attracted to sites of inflammation and infection. At a molecular level, there's a defect in the STAT3 signaling pathway. STAT stands for signal transducer and activator of transcription, and it's a signaling pathway that's activated by cytokines, and it doesn't react appropriately in people who have hyper-IgE syndrome. People with this condition have an overproduction of IgE, obviously, that's why it gets its name. They also have a loss of interferon gamma, and you can find this when you do lab tests. You can find high levels of IgE and low levels of interferon gamma. Now, how these alterations affect the T cells and the neutrophils in the signaling pathway are not known. As I said before, this is a very complex, poorly understood disorder. So what are some of the findings of hyper-IgE syndrome? Well, first, there are those skin findings. These occur in babies in the first few weeks of life. They develop diffuse eczema, and eczema is a diffuse red itchy rash. This is a picture of someone with eczema on their hands. The babies can also get crusted lesions and boils. They have lots of histamine release and lots of itching. Another classic finding of this condition are staph abscesses on the face and scalp that are cold. Normally abscesses are warm because they have neutrophils and other inflammatory markers inside the abscess. That is not the case here. These children have immune dysfunction, so their abscesses lack warmth and redness of inflammation. If you hear discussion of a cold abscess, that's a classic finding for hyper IgE syndrome. Other problems include recurrent sinusitis and otitis, sometimes without fever, again, because they have defective T-cell help and defective cytokine production. In addition to the skin findings and the immune system dysfunction, these babies tend to have facial deformities. There are many that are described. A broad nasal bridge is one of the common findings. And in addition, as they grow older, they tend to retain their primary teeth, and thus children can have 2 rows of teeth when they have this disorder. So the classic case to know for your boards is going to be a newborn baby who has a deformed face or teeth with a diffuse rash. They will describe skin abscesses that are cold. Remember, this is the classic finding. The baby will suffer from recurrent infections, often without fever. Lab tests will show elevated IgE, and the question may ask you about the Th17 cells or the loss of neutrophil attraction. Our next immunodeficiency syndrome is called chronic mucocutaneous candidiasis, and as the name implies, people with this condition get recurrent candida infections. This condition results from defects in autoimmune regulator genes called AIR genes, and AIR genes have 2 important functions that are relevant to chronic mucocutaneous candidiasis. The first function is that they associate with the dectin-1 receptor, and the dectin-1 receptor is the receptor that responds to candida antigens. So when you have defective AIR genes, the result of the defect is that you cannot respond to candida antigens and you get recurrent candida infections. The second AIR function is that they promote self-antigen production in the thymus, and recall that in the thymus, self-antigens are presented to T cells. This is part of the process of negative selection. T cells that bind too strongly to self-antigens are clonally deleted. So as a result of AIR gene dysfunction, you do not have proper self-antigen presentation to T cells, and as a result, you can have autoimmune T cells that develop. And the result of the autoimmune T cells in this condition are that they attack certain endocrine glands, especially the parathyroid and adrenal glands. And as we shall see, people who get these recurrent candidal infections from this disorder also have problems with parathyroid and adrenal dysfunction. This condition is not completely understood, but the best evidence suggests that it's a primary T cell problem, a cell-mediated immune defect. There's evidence that there's decrease in Th1 cytokines like IL-2 and interferon gamma. There's also evidence that there are high levels of IL-10, which is an anti-inflammatory cytokine. Of note, this is not due to antibody or B-cell deficiencies. In most cases, it's a T-cell problem. The T-cells fail to react to candida antigens. So people with this condition have chronic skin and mucous membrane candida infections. They may have thrush in their mouth. They may have candidal skin infections. They may have candida esophagitis. And this will be associated with evidence of endocrine dysfunction like hypoparathyroidism and adrenal failure. And the classic case is a child who has recurrent thrush and diaper rash and also has evidence of parathyroid or adrenal dysfunction. Let me make an important side note about candida infections. The T cells are very important for mucosal defense against candida. As an example, HIV patients often get thrush. They also get candida esophagitis, and that's because they have dysfunctional T cells and low CD4 T cell counts. On the other hand, neutrophils are very important for systemic defense against candida, especially for defending the bloodstream from candida infection. And as evidence of this, HIV patients rarely get candidemia. They get mucosal infections but not bloodstream infections. In addition, you rarely see candidemia in chronic mucocutaneous candidiasis. Where you do see candidemia is in chemo patients. This is a big problem on bone marrow transplant units, and that's because chemotherapy patients are neutropenic and they lack functioning neutrophils, so they are at risk for the bloodstream infections. Our next immunodeficiency syndrome is called severe combined immunodeficiency, or SCID. Patients with this condition lose both cell-mediated and humoral immunity, so they have lost the entire adaptive immune system. It's usually a primary T cell problem, and the loss of B cells and antibodies is secondary to failure for B cells to get stimulated by T cells. For step 1, you need to know that the T cell and B cell areas of the immune system will be absent or diminished. So, for example, there will be loss of the thymic shadow. Now, I said before, you can see loss of the thymic shadow in DiGeorge syndrome, and that's true. But in DiGeorge syndrome, you also have problems with the palate and the face and congenital heart defects. SCID is purely an immune system disorder, and there aren't any of those other extra immune abnormalities In addition, you'll lose the germinal centers and the nodes because you don't have proliferating B cells. Children with this condition are susceptible to many infections. If you've ever seen children that live in a bubble, those children have SCID, and some of their parents have placed them in a bubble to keep them free from exposure to pathogens. So these children can get thrush as well as bacterial and viral and fungal infections. As babies, they may present with recurrent thrush and diaper rash and failure to thrive, and children with this condition will die unless they receive a bone marrow transplant. There are lots of genetic abnormalities that can lead to severe combined immunodeficiency, but the most common forms are X-linked and therefore occur predominantly in boys. One of these that's very common is a mutation in the gamma subunit of cytokine receptors. There is a gene called the IL-2RG gene, which stands for interleukin-2 receptor gamma gene, and mutations in this gene have commonly been associated with SID. There's also a mutation in the adenase deaminase gene, which can lead to SID, and I'll talk about that in a minute on the next slide because it is a tie-in with biochemistry. Babies in the U.S. are screened for SID. Unfortunately, you can't do a T-cell count because T-cells from the mother may give the baby a falsely normal T-cell count at birth. Instead, what are measured are things known as Tregs. Tregs stand for T-cell receptor excision circles. These are circular bits of DNA that are formed in the normal T-cells in the thymus. So if the Treg count is low, that suggests the baby may have SID. And this is mandated in many states in the U.S. as screening among newborns. So the classic case to know for your boards is an infant with recurrent infections, often in multiple different systems. There may be otitis media and GI infections and Candida skin infections. There will often be an absent thymic shadow reported on chest X-ray. And importantly, they will have normal calcium and a normal heart. And that's how you know that this is not DiGeorge syndrome, because patients with DiGeorge syndrome have parathyroid dysfunction that leads to calcium abnormalities, and they have congenital heart defects. Adenosine deaminase deficiency is the reason some children develop severe combined immunodeficiency. If you look at this illustration on the bottom of the screen, I've shown you what the enzyme adenosine deaminase does. It converts adenosine into inosine, and it does this by removing an amine group. That's called a deamination reaction, and it removes this amine group and replaces it with an oxygen. So it can convert adenosine and deoxyadenosine into inosine and deoxyinosine. If adenosine deaminase is dysfunctional, you will get high levels of adenosine and deoxyadenosine, and this can lead to high levels of deoxy-ATP. The problem with high levels of deoxy-ATP is that it is believed to inhibit ribonucleotide reductase enzymes. These are enzymes that convert ribonucleotides into deoxyribonucleotides. So you need this enzyme functioning in order to create the building blocks of DNA, which are deoxyribonucleotides. So in the presence of high levels of DATP, you get reduced building blocks for DNA. As a result, you have reduced DNA synthesis, and this leads to B and T cell dysfunction. Let's move on to our next disorder, which is called ataxia telangiectasia. This is an autosomal recessive genetic condition. In order to get this condition, both of your parents have to carry an abnormal gene called the ATM gene on chromosome 11. ATM stands for ataxia telangiectasia mutated gene, so obviously it goes with this condition. This gene is responsible for repairing double-stranded DNA breaks by a process called non-homologous end joining, which we'll talk about in a minute. So if you have a defective ATM gene, you are unable to repair DNA mutations, and as a result, patients with this condition have hypersensitivity of their DNA to ionizing radiation. So this is a very rare condition, but one of the reasons Step 1 likes to ask you about it is because there's a tie-in with molecular biology. The process of non-homologous end joining is a process by which double-stranded DNA breaks are repaired. So if you have a double strand of DNA, as I've shown here, and you're exposed to some ionizing radiation, then you can have a break in your double-stranded DNA like this. And the process of non-homologous end joining directly brings these broken ends together and repairs them. As a result, it splices out some of the nuclear material in the middle, but at the end you have a repaired DNA strand that is put back together. You can contrast this process with homologous DNA repair, which is a process that occurs when there is an identical DNA strand to the broken strand that can be used as a template. When there isn't a template strand available, then this process of non-homologous end joining occurs. And you don't realize it, but we're exposed to ionizing radiation all the time from the sun and from other sources, and our bodies have evolved mechanisms to repair this damage routinely. People who have ataxia telangiectasia are unable to do this process, and as a result they accumulate DNA damage over time as they're exposed to radiation in everyday life. One of the confusing things about this disorder is that many different organ systems are involved with varying findings, and it's not known how the defects in the ATM gene tie in with all the clinical findings. Luckily, two of the systems that are involved are in the title of the disease. So central nervous system symptoms include ataxia, and that's in the name of the disorder. And the skin findings are lesions called telangiectasias, which is also in the name of the disorder. Telangiectasias are small blood vessels that you can see on the face and in the skin. And then finally, people with this condition get lots of immune system findings. That's why we're talking about it in the immunology module. So they are vulnerable to infections. We'll talk about that in a minute. And because of all that DNA damage they accumulate, they develop malignancies, and that's usually how they die, is from a malignancy. This condition presents in childhood with progressive symptoms, and usually it begins with the ataxia symptoms. So parents will bring their child to attention for gait and balance problems, and that will lead to a diagnosis. So let's get more specific about the symptoms. These children will develop cerebellar atrophy, and they will have ataxia in the first year of life. This will present as falls and gait problems. They will develop telangiectasias, which are a dilation of capillary vessels on the skin. If you Google this, you can find lots of examples of what a telangiectasia looks like online. These children get repeated sinus and respiratory infections, lead to low levels of immunoglobulins, especially IgA and IgG. And then finally, they're at high risk of cancer, especially lymphomas, and this is from accumulated DNA damage over time. Commonly identified lab abnormalities when these children are worked up include an elevated level of alpha-fetoprotein. Why alpha-fetoprotein is high is not clearly understood, but that is commonly seen in ataxia telangiectasia. And then there's often a low IgA level. As I said, IgA is one of the antibodies that's usually abnormal in this condition. Our next disorder is called the hyper-IgM syndrome, and this is a disorder in which B cells cannot class switch. As we discussed in the B cell module, all B cells begin by producing IgM antibodies, but then they class switch and start to make IgG and IgA and other antibody types. In this disorder, they can't switch, so they continue to produce IgM. Usually this disorder occurs because of a failure of the B cell surface marker CD40 to bind to the T cell CD40 ligand. In about 70% of cases, it's because of a defective CD40 ligand on the T cell, so it's actually a T cell problem, even though the B cells are having trouble making antibodies other than IgM. As I said before, in this disorder, B cells make only IgM. Labs will show high levels of IgM, which fits with the name hyper-IgM syndrome, but all other antibody types will be absent. And the most common form is an X-linked disorder that occurs most commonly in boys. This is a picture from our B cell module showing a fully activated B cell via the T cell dependent activation pathway. A B cell has to bind and cross-link an appropriate antigen, and then its CD40 surface marker must bind to the CD40 ligand on T cells, and this interaction is required for class switching, and this interaction is what's defective in the hyper-IgM syndrome. And as I said before, it's usually defective because of a problem with the CD40 ligand right here on the T cell. So people born with this condition have recurrent bacterial infections starting in infancy. They are usually sinus and pulmonary infections like pneumonia and sinusitis and otitis media, and mostly they're caused by encapsulated bacteria like strep, pneumo, and H. flu. The reason you suffer encapsulated bacterial infections with this syndrome is because you cannot make IgG. And as we've discussed in several of our immunology modules, IgG is very important for coating encapsulated bacterial and marking them for phagocytosis. Children with this condition also get some opportunistic infections like pneumocystis and cryptosporidium and histoplasmosis. Wiskott-Aldrich syndrome is a very rare X-linked disorder of the Wiskott-Aldrich syndrome gene, which codes for the WAS protein. And if your WAS protein is absent or dysfunctional, you will have abnormal maintenance of the T cell cytoskeleton. And the word cytoskeleton is a buzzword for this condition. And when you have this problem, you have abnormal T cell function. The cytoskeleton is important for forming something called the immunological synapse. This is the way that T cells react to antigen-presenting cells. So in this disorder, the T cells cannot properly react to antigen-presenting cells, and therefore you have T cell dysfunction. This syndrome can worsen with age. Some children are born with some functional WAS protein, and then that amount of functional protein declines as they age. The people with this disorder obviously get immune dysfunction because their T cells don't work. In addition, they have low platelet counts. The mechanism for this is incompletely understood, but it seems to get better after splenectomy. So there is some consumption of platelets that occurs in this disorder. And then finally, people with this disorder often suffer from eczema. They have a lot of hypersensitivity. You can find elevated IgG and IgA levels when you do antibody testing on these patients. And you can treat the Wiskott-Aldrich syndrome with a bone marrow transplant, which restores normal T cell function to the patient. So the classic case of Wiskott-Aldrich syndrome is a male infant about 6 months old when the maternal antibodies fade, who develops eczema and then bleeding and petechiae from the low platelets. And this disorder is unique among the immune deficiency disorders. None of the other disorders give bleeding and petechiae and low platelets. As soon as you see this, you should think of Wiskott-Aldrich syndrome. And then finally, they will develop recurrent infections from the T-cell dysfunction. Our next immune deficiency disorder is called the leukocyte adhesion deficiency, and Step 1 of the boards likes to ask about this because they use it as a way to test you on the process of neutrophil migration to sites of inflammation. People with this disorder have defective neutrophil and lymphocyte migration. The most common type is called type 1, and people with this condition have an autosomal recessive defect in CD18. CD18 is also called the lymphocyte function-associated antigen, or LFA1, and it forms a subunit of several integrins, and integrins are very important for white blood cell binding to capillaries and then rolling and migrating to sites of inflammation. These are adhesion molecules. So when you have this disorder and the integrins are abnormal, white blood cells, especially neutrophils, cannot roll and migrate to inflammatory locations. There's a classic presentation of this in a newborn baby that's very easy to recognize in a board question stem, and it's delayed separation of the umbilical cord. So after the umbilical cord is cut in a newborn baby, inflammation occurs, and the cord stump normally falls off in about 2 to 3 days. This is a picture of a baby that's a day or two old, and you can see the cord stump right here. It's turned dark and necrotic, and it's going to fall off very soon. In leukocyte adhesion deficiency, there is a delay in that stump coming off. Sometimes it takes more than 30 days for it to fall off. In addition, another classic presentation is something called omphalitis, which is a stump infection. So in a board question, this will always be a baby whose stump has not fallen off and now has evidence of infection. That child has leukocyte adhesion deficiency, and the reason for those symptoms is because the neutrophils can't get into the umbilical cord stump. Other findings that these children have are recurrent bacterial infections because neutrophils can't get to sites of infection, and they will have an elevated white blood cell count. They will have a neutrophilia. There are lots of neutrophils in their blood, especially during infection, but they can't leave the blood, so therefore when you measure the plasma white blood cell count, it will be increased. The Shediac-Higashi syndrome is a failure of lysosomes to fuse with phagosomes. It's a mutation in a lysosomal trafficking regulator gene called the LIS gene, and as a result you get microtubule dysfunction. So the buzzword here is microtubule. You need those microtubules to bring the lysosomes and phagosomes together, and that does not occur in this disorder. As a result, these children have recurrent bacterial infections. Staph and strep are especially common. And then a unique feature of this disorder that makes it very easy to recognize in a board question stem is that these children have something called oculocutaneous albinism. This means they have fair skin and blonde hair and light blue eyes. The reason for this is that there are granules containing pigments in your cells that are also transferred around via microtubules. And when the microtubules are dysfunction, they don't get transferred properly, and as a result, these children end up with all the features described here. Children who survive suffer severe neural impairment. They get peripheral neuropathy and weakness and sensory defects, and they're often wheelchair-bound very quickly. Chronic granulomatous disease is a loss of function of the enzyme NADPH oxidase. Recall that phagocytes use NADPH oxidase to generate hydrogen peroxide from oxygen. This is a process called the respiratory burst, and the hydrogen peroxide is toxic to bacteria, and this is one of the ways that phagocytes can kill bacteria. Patients with this condition generally do not get infections from catalase-negative bacteria. And why is that the case? Well, catalase-negative bacteria generate their own hydrogen peroxide, and they cannot break it down because they do not have catalase, which is the enzyme that breaks down hydrogen peroxide. So the phagocyte can use the hydrogen peroxide made by the bacteria despite their enzyme deficiency. Catalase-positive bacteria, on the other hand, can break down H2O2, and therefore there's nothing for the phagocyte to steal, so host cells have no hydrogen peroxide to use and they get recurrent infections. So 5 organisms, all of which are catalase-positive, cause most of the infections in chronic granulomatous disease. Those pathogens are Staph aureus, Pseudomonas, Serratia, Nocardia, and Aspergillus. And here's an illustration just to help you remember how this disorder causes disease. So oxygen is converted to oxygen radicals by NADPH oxidase, and then that is converted into hydrogen peroxide, which will go on to kill bacteria. In people who are born without functional NADPH oxidase, they cannot perform this process called the respiratory burst, and therefore they cannot kill bacteria. Catalase-negative bacteria make their own hydrogen peroxide, and the phagocyte can steal that and use it to kill the bacteria. Therefore, they can kill bacteria despite missing NADPH oxidase function. Catalase-positive bacteria, on the other hand, break down their own H2O2 into water and oxygen, and therefore there's nothing for the host cell to steal, and therefore phagocytes cannot kill the bacteria and they go on to cause infections. There's a screening test for this condition called the nitro-blue tetrazolium test. Dye is added to a sample of neutrophils, and in the absence of NADPH oxidase, the cells do not turn blue. It's called a negative test when there's a lack of NADPH enzyme, meaning the cells do not turn blue. More blue means more NADPH oxidase present, which is what you see in a normal person. That's the last of our immunodeficiency disorders, and let me just finish with this summary slide. Most of the disorders we've discussed in this module are disorders of adaptive immunity. They are problems with B cells or T cells or antibodies. But the last three disorders we discussed are all problems with innate immunity. So in the leukocyte adhesion deficiency disorder, you have decreased neutrophil migration. In the Shediac-Higashi disorder, you have a failure of lysosome fusion from a microtubule defect. And in chronic granulomatous disease, you have loss of the respiratory burst and catalase-positive infections. And I mention this because sometimes the boards will simply ask you whether or not a problem involves adaptive or innate immunity, and you should be aware that these are the only three disorders we discussed in this module that involve problems with innate immunity. And that concludes our module on immunodeficiency syndromes.